Okay, so we're going to talk about neurologic infections in the next few lectures or next few sections. First is meningitis. Meningitis is inflammation of the meninges. Bacterial meningitis is the most serious, and it is the one we're the most concerned about. But we also can have viral meningitis. So bacterial meningitis is most frequently caused by H. flu, strep, pneumonia, Neisseria, meningitis, group B strep, listeria, or meningococcal disease. So meningococcal meningitis is the one with the most potential to work very, very, very quickly. We have vaccines against a couple of these now, so meningitis outbreaks have decreased in frequency. H. flu is covered by Hib. There is a meningococcal vaccine, which is required usually before going to college. And that's because it's spread by droplet in contact with saliva and nasopharyngeal secretions. So again, kind of like mono, who is drinking after each other and passing things around? High school, college age kids or students, college age adults. So what does this look like? Bacterial meningitis may travel from another site of infection through the bloodstream, or it may originate with a penetrating wound or a skull fracture. So basilar skull fractures are the most common because they go undetected. So think about, we have an infection somewhere else, it travels through the bloodstream and infects the meninges, or we have a disruption in the meningeal layers, that protective layer, and then we get infection. So what happens is the brain gets hyperemic, so it's has an increased blood flow, it swells, and it's covered by purulent exudate. So think of this, think of the brain red, swollen with pus on it. Pus, fibrin, or adhesions can obstruct the flow of cerebrospinal fluid, causing hydrocephalus. So we have potentially increased intracranial pressure from the swelling, and now we have increased intracranial pressure from hydrocephalus. They have fever due to the inflammation. They may have all the signs of increased intracranial pressure. Also, they may have nuchal rigidity and back pain because of the meningeal irritation. So when they nuchal rigidity is when they can't bend their heads forward without extreme pain. They may also have back pain. At its worst, they may actually have a be like opisthotonus. That's the word I'm looking for, where they severe meningeal irritation. They're in a spasm that's so severe that like the head and the heels are touching the bed and everything else is arched in that spasm. So that's really severe meningeal irritation that begins with my neck won't bend forward. Okay. The signs of increased intracranial pressure: nausea, vomiting, irritability, headache, photophobia, that light hurts their eyes, confusion. Okay, and then we add those symptoms of meningeal irritation. Kernig sign is when the patient is placed supine with their hip and knee flexed. That causes pain in the hamstrings, and they're not able to extend more than 135 degrees. Brzezinski sign is when the patient is placed supine. When we flex the neck, the lower extremities flex involuntarily. So those are some things that would also indicate meningeal irritation. Now, if they have a petechial rash, they may also have sepsis. Meningococcal disease frequently develops into sepsis, so they have meningitis and sepsis. It is the most likely to be fatal, to be rapidly fatal. They eventually can develop seizures, decreasing or deteriorating level of consciousness, because of the increased intracranial pressure, and that pressure can become enough to herniate. Okay. Diagnosis: if this is suspected, they need a lumbar puncture for a gram stain, blood cell count, glucose, and protein. So if there's bacterial infection in the cerebrospinal fluid, it uses up a lot of the glucose, so the glucose that should be there will be lower, protein would be higher, blood cell count would be higher. They would have more white cells, and then hopefully they can culture out whatever the organism is. The spinal fluid pressure is usually elevated, so that that lumbar puncture needs to be done carefully. If it's suspected that they have increased intracranial pressure, they need a CT scan before the lumbar puncture, because remember, if we have increased pressure and then we do a lumbar puncture, it can cause herniation. They also are going to have an elevated white count, which makes sense with a severe bacterial infection, right? So management: any patient who is suspected, this is really, really important, any patient who is suspected to have bacterial meningitis, the very first thing that we do is isolate them. Immediate respiratory isolation. Okay. And then antibiotics are initiated immediately. We don't wait for cultures. We get antibiotics going. We want to restrict hydration. We don't want them to be overhydrated, because that increases brain swelling. And then we're managing is supportive care. We're managing the airway, breathing, circulation, managing their intracranial pressure. If they're in shock, that has to be managed. If they have seizures, that needs to be controlled. We need to try to control their temperature. Their temperature can get high enough to damage brain tissue. Steroids may be used to decrease the risk of herniation. They don't know if it has any effect on long-term complications, but steroids can be used to get the swelling down quickly to prevent herniation. For prevention, we want to really encourage vaccination, and anyone who's suspected to have a bacterial meningitis should be isolated. Fewer than 10% of cases are fatal, but long-term physical and neurologic complications are common. So some of the common complications are hearing loss, cognitive disability, motor disorders like spasticity or paralysis, and seizure disorders. When we talk about isolating people who are suspected to have meningococcal disease, to prevent outbreaks, frequently close contact, people who've been in close contact with them are going to also get prophylactic treatment, even if they don't have symptoms. Now, viral meningitis has similar symptoms to bacterial, but when they culture the CSF, they don't get any bacterial growth. Viral meningitis is usually self-limited, short duration, and they're a lot less likely to have complications. But the symptoms are the same. So if someone comes in with symptoms of meningitis, we treat them like it's bacterial until it's confirmed that it's not. All right, next section, we're going to talk about encephalitis.